Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Today, we are joined by Ms. Allison Kumnick and Dr. Belkowitz, who discuss a simulation-based approach to improve medical students' resilience and communication, as well as educate faculty members on unintentional discriminatory practices. Today, they will also detail what led them to develop their project, the findings of which they and their co-authors present in the upcoming Southern Medical Journal article, Developing Awareness and Allies, Simulating Difficult Conversations about Microaggressions for Faculty and Students. Thank you both for being here today.
Thank you so much for having us.
Discrimination is often experienced among medical students in clinical settings, especially those who belong to ethnic or gender minority groups, and can occur in forms of microaggressions. Can you share with our listeners what microaggressions are?
Yeah, absolutely. So the term microaggressions was first coined by an African-American psychiatrist named Chester Pierce around 1970. But the definition was later refined by Darrell Sue and his colleagues as commonplace verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults towards people of color. So basically, microaggressions are one of many ways that people can exhibit biases towards minoritized groups. Oftentimes, these take the form of unintentional comments that may or may not be interpreted differently by different people. So some examples in medical education might include thinking that the Black medical student is a nurse or a tech, but the white medical student is a doctor. Another example might be referring to a student's hairstyle or the way they present themselves as unprofessional just because they don't adhere to the norms of typical white American professionalism. One thing I do really want to clarify is that the term microaggression was coined by a Black academic to describe racial bias and was popularized by the Black community. Over time, the usage has expanded to sometimes include other marginalized groups, which is how we are using it in the context of our study and this discussion today. And we really hope that that's okay with all of the listeners.
I can just add a little bit that one of the reasons that we wanted to add this into the curriculum for our medical students is because it's a really important time now that both our faculty and students are able to recognize microaggressions. Because each year as we matriculate new students into our medical schools, our community of learners actually becomes more and more diverse. And we have students who belong to groups that have been historically underrepresented or not even represented at all in medicine. And medical school faculty typically are not as diverse as the learners that they are teaching. And so this can lead to a lot of misunderstandings or interactions, which can actually be hurtful to our students and ultimately impact their education. So as institutions, we really need to assure that we are prepared to provide a learning environment that is safe and one in which our students really feel supported.
Thank you so much for providing some details about microaggressions. Knowing that these can lead to poor mental health and well-being, as well as to burnout, did those aspects help motivate you to undertake this project?
Yes, I mean, it definitely did. It's very well documented that both physicians and medical students experience high levels of depression and burnout. But what is especially concerning is that students whose racial and ethnic identities are underrepresented in medicine are actually even more likely to report burnout than their peers. So based upon this evidence, it's clear that we do need to provide some sort of formal training to both our students and faculty on the topic. But as with many things, what really actually motivated us to take on this project were the stories that we heard directly from our learners. Our students would come to us to talk about experiences that they had in the clinical environment that were painful or uncomfortable, and they often felt ill-equipped to handle them in the moment. Students also struggle about how to respond just because of the inherent hierarchy that exists in the training process. So even a student who may otherwise feel skilled or empowered to address or even question a microaggression out in the community or in conversations, even in the classroom or with their friends, the dynamic is really different when they're placed in the situation in which someone is supervising or evaluating them, and that person is the one making the comment. And then, of course, the dynamic can be even more complicated if the patient is the person that's actually saying the hurtful or insensitive comments. So I remember talking with my colleagues about one particular student who came to us after experiencing some difficult encounters in which a faculty member was actually being disrespectful about a patient. And this led the student to question actually whether she even belonged in medicine at all. And that was, just so horrible for us to hear. So we realized that at the same time that we really are working to change the culture in our institutions and really are actively providing direct feedback to faculty who make inappropriate or insensitive comments, we may never really be able to create a space that's 100% safe or completely free from comments that may be difficult for our learners to hear. And this is really especially true when we talk about microaggressions, is because sometimes the person saying them may not even realize that what they said was hurtful. And that may be from a lack of understanding or just a lack of experience. So that's when we decided that we wanted to create a training that could empower students, provide them tools to respond to these uncomfortable situations, and most importantly, to help them feel resilient, even after they experience something that may be really difficult for them. And so at the same time as we are working towards changing the learning environment, we wanted to also provide parallel training for faculty to help them understand some of the perspectives from the student experience, and provide a learning opportunity for them as well. And I know Allison and her classmates had talked a lot about this as well.
Yeah, so my experience with this project actually began many months prior. Myself and some of my colleagues hosted what we called a roundtable discussion to talk about some incidents of harassment that we had experienced in the first half of our third year clinical rotations. So the group that came together was very diverse in terms of race, sexual orientation, and gender identity. And we all told stories of sexual harassment or of racist comments or of misgendering that had happened during our clinical rotations. And we really focused on how the medical hierarchy had played into our experiences and many times exacerbated the negative impact that these incidents had had on us. For me, something that really stuck out was how the intersectionality of different identities played into these stories. So many women had experienced sexual harassment, but for example, each time my classmate who was a person of color had been sexually harassed, there were also elements of racism there. And for me, this really emphasized that for this particular project, we needed to attempt to address as many areas of bias as possible.
You've touched on what motivated you to undertake this project. Could you tell us a little bit more about the project itself?
Absolutely. So towards the end of my third year, Dr. Belkowitz came to myself and some of my colleagues with these simulation cases that had been used in past year's clinical orientations and asked us to modify and update them for the incoming third year orientation group. So we really wanted the new cases, the updated cases, to be super realistic based off of these conversations that we had had during our roundtable discussion. We didn't want them to be an extreme example of discrimination, but rather something that all the future students would likely encounter at some point. So in the end, we came up with 4 cases, and I'd like to summarize them for you right now. So the first case, this case actually doesn't have a lot of elements of discrimination, but it was from the past cases, and we decided to keep it because it's something that we really commonly encountered, and that is of the unsatisfactory medical student performance. So this case is about a medical student presenting on morning rounds, and the attending is very disappointed with the student's lack of familiarity with the patient's case, and the attending reacts really harshly and reprimands the student. So again, there's not really a discriminatory element to this, but something that we commonly encounter, and we kept this case as our first case. The second case was more based off of the roundtable discussion, and this was of the quote unprofessional attending at lunch. So this case is about a student having lunch with their surgery preceptor one-on-one, and the preceptor makes a comment about the student's future ability to have both a career and a family. And additionally, the preceptor makes a partisan comment on the political climate. This came out of our roundtable discussion. I was during my third year rotations during an election cycle. It was a highly politicized time, and I did hear a lot from different doctors in the clinical setting, and it was always uncomfortable because you don't want to engage in that kind of discussion with someone who's evaluating you. Additionally, of course, it's very common for people to be discouraging, especially towards women, about balancing both a career, especially maybe in surgery, and having a family. The third case was based off of the experiences of a lot of my classmates who were people of color. and this was called the mistaken identity. And this was a microaggression by the chief resident who compliments a medical student on their patient presentation, but based on their physical appearance, incorrectly assumes that the student speaks a foreign language, and then also confuses the student for another student of color who is interested in a different specialty. So this was something that I heard a lot from my classmates who were people of color, that they would be confused for other people of color during the rotations, especially because you're in and out of so many different clinics, sometimes for a really short period of time. And then finally, the last case was about inappropriate patient comments, something that Dr. Belkowitz briefly spoke on. And this is about a team rounding in the morning, and the patient makes an inappropriately sexual comment about one of the medical students. And again, this is a really difficult thing because we don't want to, reprimand or yell at our patients or anything, but it can make people feel really uncomfortable in the moment. And so for the students to actually participate in these simulations, it was the whole incoming third year class, about 200 students, and they were put into Zoom breakout rooms in groups of 4. So each breakout room had a standardized actor who played a part in the case and then also facilitated a short discussion at the end. Because there were 4 students in 4 cases, each student played an active role in one of the cases, and all the others participated in the discussion at the end. And then after all the cases were done, there was a larger group debriefing and a longer discussion that was led by one of our med ed faculty members. So we really wanted to assess how helpful these simulations were. So we created pre and post simulation surveys. The surveys assess students' confidence level rated out of 10 with handling difficult encounters with faculty, residents, patients, and others. And we were also able to send out the surveys 6 months after the simulation, so 6 months into their clinical rotations, to assess how the participants had felt the simulation had prepared them. Then finally, we took the cases and we flipped around the point of view for presentation to the faculty. I personally facilitated the faculty training where I presented the cases and prompted the group of faculty for discussion. We also had made a pre and post survey for the faculty, which included a few other questions about their familiarity with terms like microaggressions and their proactivity about educating themselves on the topics.
The simulations addressed both student and faculty training. Why do you believe this was important?
Yeah, it's a great question. Thank you for asking that one. It was really a great benefit for us to be able to work with the University of Miami Gordon Center for Simulation and Innovation's standardized patient program so that we could simulate realistic encounters for our students prior to them starting their rotations. As Allison had said, we had previously done a similar exercise using small groups and role plays for discussion, and it was definitely worthwhile, but the simulations were much more valuable for our students because they had the opportunity to experience what it actually might feel like in the moment, practice the actual words of how they might respond, and then reflect and debrief with others to help them feel prepared, as they're embarking on this really new phase of their education, which is the clinical environment. It really is such a different time. And we did feel that the faculty component was also really important to ensure, as I said before, that our medical education leaders as well, such as clerkship directors and program directors, were on the same page, kind of using this idea of a shared mental model that we use in other ways in healthcare so that our students and faculty were using, similar vocabulary about what students experience as they go through the rotations. And it was really terrific. It was so valuable because Allison led the majority of the faculty training, as she just said. And I think it was much more impactful this way because not able was she only to be able to provide content and definitions that may have been new to faculty. She was able to provide her perspective on what it felt like as a student to experience microaggressions in the learning environment and to share how demeaning and discouraging it really can be for them. And this is something that we could not have conveyed just in conversations amongst ourselves or faculty. So that simulation and really active engagement was really an important part of the curriculum.
As the sessions continued, did you find any of the results or anything that came out of these to be surprising?
Well, I can start with you by sharing a little bit about what the results were that we found. So we were pleased because all of the confidence scores that we asked people to report did improve in the pre to post survey. Confidence in communicating with a faculty member during an uncomfortable encounter was actually the one that was the most challenging. It had the lowest score, both pre-test as well as post-test. And it's probably not surprising based upon what we talked about before about the hierarchy. And it shows that they're really inherently nervous about communicating with those that evaluate them. The largest increase that we saw was confidence communicating during an uncomfortable encounter with what we called another member of the healthcare team. So someone that was not a faculty member or not a student, but it could have been a resident or a nurse or one of the many other people that our students encounter in their day-to-day clinical activities. And generally, students reported feeling more prepared for these scenarios in the post-survey. And after the 6-month follow-up, when they'd actually had time, that they spent in the clinical environment on their rotations, they did reflect and share that this had been helpful. A quote from one of our students said that basically, that these practice scenarios actually helped prepare me for the challenging situations I sometimes found myself in during clerkships. And when I encountered difficult situations, I reflected on how I approached the scenarios we practiced, and it helped me to navigate them. And that was really rewarding for us to be able to see a student say, wow, I was able to kind of pull back on that moment, those discussions that we had early in the start of the 3rd year, and it helped me in that moment, as I was moving through my training. I know, Allison, you had your own perspectives as well, having been working with the faculty.
Yeah, absolutely. So I was honestly surprised about how open the faculty members were to discuss these topics and to admit the things that they didn't know. I was really nervous going into giving this presentation because I didn't want the faculty to feel like I was attacking them, but I knew that this was a really important opportunity for me to advocate for both myself and my peers. So in our pre-session survey, 53% of the faculty said that they definitely knew what a microaggression was versus 100% after. And this was probably because I defined it for them like I did for you today. But it was really good to just put this all out there and make everyone familiar with the vocabulary that we were using. We also asked faculty about how they educate themselves on social issues in order to improve competency for teaching medical students. And I do think the results of this are pretty important also. So 53% said they read books, 29% watch documentaries, 47% attend seminars, and 71% of faculty say they do research when an issue arises. The largest increase in the confidence score for faculty members from the pre to the post survey was their confidence and their ability to use preferred pronouns besides he, his, and she, hers when asked. This wasn't too surprising for me because I know it's not been super common for alternative pronouns to be used in the clinical setting, but this is really, really important to address now because more and more young people are identifying as genderqueer, and 1 in 4 LGBTQ youth uses pronouns besides he or she. So this is going to become a lot more common, and I'm glad that I was able to introduce this to a lot of faculty and make them feel more comfortable with this type of scenario.
As a result of these training sessions, what do you see regarding future improvements or changes related to addressing discrimination and microaggressions?
Well, I hope that we continuously come up with new ideas and ways to help support our students and to educate our faculty and those in the learning environment. But in the short term, based upon the feedback that we've received, this training has been incorporated into our annual Transitions to Clinical Rotations course for all of our students. So we continue to implement the simulations and facilitated discussions as a part of that course. So not only do we hope that this process helps to make the students feel more comfortable in their interactions and their self-efficacy in having these difficult conversations, we also hope that this helps to signal to students actually that we really do care about them and their education and are interested in hearing about their experiences in the learning environment. So we hope this helps more students to be able to come forward and share their experiences with us about microaggressions or other challenging situations that they may encounter. And we do also plan to provide further training for faculty in the future as well. I think that as faculty members, we all need to, remember our humility, acknowledge that we can say things that are hurtful to our learners, often without intending to do so. And while, of course, obviously, none of us want to do that, we most importantly really do need to be open to hearing about how our actions can impact our learners and be open to how we can improve. So it's really been such a wonderful opportunity to be able to hear the perspective of Allison and so many of her classmates, and we just hope to continue this important dialogue together.
Are there any final thoughts that either of you would like to share with our listeners today?
I guess I can start with that one as well. I think none of us, faculty or students really, right, will ever be fully prepared for every possible situation that comes up as we navigate the really complex learning environment that takes place in the clinical setting. It's really unique because there's so many competing challenges that have to be navigated in these environments. Of course, first balancing the needs of the patient, but we also have the learners, the other people on the healthcare team, the whole healthcare system. And so it's really important that we take whatever steps we can to help the entire team navigate the challenging conversations that are just bound to take place in an environment such as this one. So we do hope that the trainings like this can serve as a mechanism to support our students by providing them the time and opportunity to reflect and plan for, the inevitable challenges that are likely to happen. Allison, I think the student perspective is really important on this one as well.
Yeah, of course. As I wrap up my medical school experience, I find that although these types of projects require a lot of work, it's totally worthwhile. And it's one way for me personally to leave this institution that's given so much to me a little bit better than I found it. I'd also like to thank my friends and colleagues who worked on this with me all the way from the discussions up to writing this paper. Now they're out there all over the U.S. doing great work in different residency programs. And then, of course, thank you to Dr. Belkowitz and the faculty who supported this and pushed 200 students through these simulations and will continue to do so even after we're gone. Finally, thanks to the journal for being willing to spread this message and publish our work. These experiences really do make a difference in our medical education. And it's really true that if we can learn in a safe and welcoming environment, then we can focus on becoming the best doctors possible for our patients. So thank you.
Thank you both for being here today. This has been a really informative discussion. And again, we appreciate your time.
Thank you so much for the opportunity.
Yeah, thank you.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.